Dear Chairman, dear audience, my name is Dániel Pálinkás, and let me introduce my scientific project and in the next 10 minutes. So the topic of it is the proper way of anticoagulation after the gastrointestinal bleeding. I'm working as a gastroenterologist in one of the biggest Department of Gastroenterology here in Hungary, and we frequently treat patients with gastrointestinal bleedings. And my vision, I want to improve the management of these patients, and especially patients who are taking anticoagulations by the time of the gastrointestinal bleeding. I've got two running projects. In the first, we assess the safety and efficacy of anticoagulation therapy after a gastrointestinal bleeding based on the already existing data. And in the second project, we focus on one question, in the timing of the anticoagulation therapy resumption. So in the first project, as I've already mentioned, this is a systematic analysis. Well, we already finishing the article draft with my supervisor. So the background of this, it's direct or anticoagulants. We want to focus only these medications. They are increasingly used in the last 10 years since they entered to the market, because it's easier for the patients and for the clinicians as well. And also they are safer than the old medications, the vitamin K antagonist, except maybe gastrointestinal bleeding, where the data are a bit conflicting, but they are at least as efficient as the vitamin K antagonists. So although they're considered to be safe medications, the annual risk of gastrointestinal bleeding is about 3% per year. And the real question comes after the bleeding. What should we do with these patients? Should we restart the therapy, or should we just leave it for a long period? From the data, if we review the data, we almost find articles and studies with vitamin K antagonists only, and there's a little proportions of patients who observed it in direct or anticoagulants. And what we see here, actually, that if we resume the anticoagulation therapy after the gastrointestinal bleeding, there's no question the risk of bleeding, the rebleeding, it's higher in those population. But on the other hand, if we permanently discontinue the therapy, the risk of thromboembolic complications and Ocker's mortality rises, and it's higher significantly. But this data is coming from the vitamin K antagonist studies. So our aim was to determine the safety and efficacy in the population of DOAC-treated patients. So we formed our clinical question and the PICO form, where the patients are those who are taking DOACs prior to the gastrointestinal bleeding. And the intervention is resuming the therapy. The control is if there's no resumption. And we observe the mortality, the thromboembolic event, and rebleeding rate. And our hypothesis is that with the resumption of DOAC therapy, the mortality and the thromboembolic complications can be lower. So we performed our systematic research, and at the end we found only 3 eligible articles for the whole study. And these are also retrospective cohort studies, so not the highest evidence at all. But so here's the first result regarding the rebleeding. Actually, it's interesting because in this case we did not find any association between the DOAC therapy resumption and the rebleeding rate, opposite to the previous studies I've already mentioned. So, because as you see, the odds ratio is 1.09 with a confidence interval cutting the line of no effect. But I have to mention here you see there's actually, in this outcome, there was not such a big heterogeneity between the studies, but if we closely observe these studies, we can see there are significant differences, not just the interventions and controls, and also there's high risk for bias due to confounding. So the certainty of evidence is very low. Actually, we have to consider this as one. In the other 2 outcomes, thromboembolic complications and all-cause mortality, unfortunately, there is no efficient data to make statistical calculations. So I present here the only one study's result, and they also do not find any significant differences between the two groups. So the strength of this study is actually that we are the first one who really want to focus only on DOACs. And if you consider that the pharmacological feeders of these two treatments are really different, you have to, then you see that there's really important to focus on DOACs, because in the next decades it will be the mostly frequently used medications. And, but there are several limitations, as you've already seen, so that the retrospective study design, the low number of studies and the patients involved in these, so the low quality of data, exactly. And as conclusions, we can say that there's no association between rebleeding and DOAC therapy resumption. And the efficacy outcomes, for sure, we do not have sufficient data for conclusions. The implications for practice, actually, first of all, we have to handle these with criticism, but we've got an inappropriately high therapy withdrawal rate by those patients, and if we just highlight this topic, we can mitigate the general fear of anticoagulation use after gastrointestinal bleeding. And the implication for research, for sure, we highlight that we need more randomized controlled trials, but we also reveal the pitfalls that have to be considered if we want to do a well-performed randomized controlled trials. So my second project is focusing on a specific topic regarding the optimal timing. So when should we reintroduce this therapy, actually? As I mentioned here, there's a study published in 2019 where they said up to 50% of the DOACs-treated patients are permanently discontinued after a gastrointestinal bleeding. And this is a huge proportion of patients. Although there are some clinical guidelines from the field of gastroenterology and cardiology as well. And they suggest, as you can see here, that anticoagulation should be resumed as soon as the bleeding has been controlled, preferably within or soon after the 7 days of bleeding event. So actually, we want to determine the ideal timing of DOAC resumption by patients who suffered a gastrointestinal bleeding. So we formed our clinical question and the PICO form, and we want to, where the population is the same, just like in the earlier, the intervention would be the early resumption, and the control would be a late resumption, and we will observe the same outcomes, just like earlier. And our hypothesis is that early resumption is not inferior to late resumption. And with these, we want to find the earliest time for safe DOAC restart and decrease the risk of thromboembolic complications and mortality. We've got the inclusions criteria. Well, we want to include only adult patients who were treated with DOACs prior to the index bleeding. And the index bleeding, we want to focus only on upper gastrointestinal bleeding, because if we just consider the different bleeding sites, there's huge heterogeneity between the rebleeding risk after a gastric ulcer or hemorrhoids, for example. So, and we only want to focus on major bleeders, and where the bleeding source was endoscopically proven and, if necessary, treated. And we want to focus only on non-varicose upper gastrointestinal bleeding, and we want to exclude all those patients for those who has a very high risk for thromboembolic complications or who have a really high risk for rebleeding. Or they do not have the indication for DOACs, because there was also some data that many patients were treated with DOACs because someone prescribed it, but not because they really need it. And we want to make two arms. The first arm would be the 3 days after, when we reintroduce the therapy after 3 days of hospitalization. We've chosen this because there are data suggesting that in peptic ulcer disease, the rebleeding comes frequently in the very first 3 days. And we've chosen the so-called late arms, where we reintroduce the therapy after the 7th days of hospitalization, because the clinical guidelines have already showed you. So, and we want to observe the rebleeding rate in the very first 30 days. It's because the incidence of rebleeding is higher than suffering a stroke or thromboembolic complications in the first week. So if we want to really observe the outcomes of stroke and systematic thromboemboli, we need plenty of, more hundreds of patients. So we really want to focus on the rebleeding rate, actually. And yes, exactly, that's what we are planning to do. I want to finish my protocol until September, and I want to start actually the trial in my hospital in the next year, well, in this year. Thank you for your attention.
Thank you for your presentation.
I have a question. I hope that I didn't miss this information, but if I remember right, you said that this is going to be a multi-center trial, and do you have any idea which centers you would like to involve in this study? Or as far as I know, you work in the military hospital, so do you have any other idea who to involve?
There has to be some criteria of the involved centers, because in this case there's need where patients, so how do you call it, bleeding patients has to be treated during the whole week and during the 24 hours. So it has to be a big center, and for sure the university centers and some big local centers are. We want to ask them whether they want to join.
My question is that you said that you would like to prove that the early resumption is non-inferior to the late resumption. So even should it be a little bit inferior, wouldn't it mean that you can still gain something if it still reduces the number of thromboembolic events? I mean, you can tell that it's safe, then you are really sure that you can resume it earlier. But are you not looking for the best you can get? Maybe if you try to compare the thromboembolic events with the risk of resumption, that would be.
Yes, because of the lack of time, I didn't have time. But actually, we also have to consider which one is the best. And in this case, if you consider that a rebleeding or a bleeding on dogs has a case mortality rate about 7%, and it occurs about 7 or 8% of the patients. And on the other hand, the case mortality rate of thromboembolic events, it's even higher, it's about 13%. And, but it occurs less frequently, about 3 or 4% in the first 3 months. But it has also some longer so for the patients, it has a long problems as well. So it's really hard because all the clinicians are fear from the rebleeding, actually, most of them. It's not because, and we want to prove if we really select those patients and we really treat them in a proper way during the endoscopy, there won't be a big difference between the rebleeding rate, actually. I don't know whether if that was the answer for your question, but for sure, yes?
Yes, so it was partially an answer. So you are mentioning that you would like to reduce the pain, and you don't really care about or not account for the gain you get from it. I mean, you can still be okay with some problems. It gives something to you. I mean, even though it could increase the chance of bleeding, it could decrease the thromboembolic events more. So you should compare the two ones, shouldn't you?
We will, but in this study, we do not. I think we do not have enough patients for proving that the stroke risk will reduce in. Because
I see. That answers the question. Thank you.